welcome everybody to our weekly conference. And today's speaker is known probably to just about all of you, Dr. Michelle Hribar, who's going to talk about work that she's done. Dr. Hribar originally received a PhD in computer science from Northwestern University and then joined our faculty, and she, I guess I can take responsibility, suggested that you should become a fellow and get formal training in informatics, and actually that worked out really well because she's just recently awarded the kind of Cadillac of career development awards, the K99R00. So we're proud of her. It didn't hurt that we just submitted our competitive renewal for the training grant and could amply brag about that and the design challenge and all the other great things that she's done. So I will let her take it from here.
Good morning, and thanks for coming. And today I'm going to be talking to you about the secondary use of EHR timestamp data for improving clinical workflows. So before I start, though, I wanted to thank the people and funding that has made this work possible. Namely the ophthalmology department here at OHSU and DMICE, Dr. Michael Chang, who's helped advise this project, and Sarah Brown and David Bierman, who have worked on the data analysis and simulations, and the clinicians who opened their clinics to us for observation and study, and the funding that made this project possible. So today's doctors struggle with efficiency. They are pressured to see more patients in less time. And unfortunately, the EHR has become kind of a source of this inefficiency. A lot of them feel like it slows them down. Studies at KCI Institute have shown that post-EHR implementation, the patient volume went down. But, you know, and clinics have used different strategies to try and overcome this inefficiency. They've added ancillary staff to do initial exams. But now patients may see multiple staff members in addition to the provider. They're often shuffled between exam rooms. And there really isn't any guidance for providers as to which patient to see next if there's a group that are waiting in terms of, you know, which is the most efficient to see next. And it can feel a lot like there's all these moving parts with no one coordinating it. And yet another airline industry metaphor for this, but sort of like you're at an airport with all these planes taking off and landing, and there's no air traffic controller to kind of coordinate the whole thing. So, and of course, inefficiency causes patient wait time. It's well known that patient wait times are a significant driver of patient satisfaction, which is a really important metric for outpatient clinics. But additionally, patient wait times can actually become a barrier to care. Patients won't return for follow-up visits if they expect long wait times. So the way we're trying to address this is building models, and we're using simulation models, that can test different clinic configurations to see if we can make them more efficient without having to do tests and use clinics as sort of guinea pigs themselves. So we can do this using the computer. And, you know, for these models, we need different types of information. We need input about, you know, how patients are scheduled, how many resources are being used, and resources would be things like staff members, exam rooms, that sort of thing. We also need data about how long all the different steps of the workflow take. And we need large amounts of this data because we have to represent the variability that's inherent in all clinics. But if we have all of this, the models can run and they can give us output. They can give us answers about essentially how long were patients waiting, how long did the clinic take, how well or how much were all those resources, the staff, the providers, the exam rooms being used. So this is where the EHR timestamp data comes in. While the EHR can actually be contributing to this clinic inefficiency, we want to see, can actually we use the EHR to actually improve processes? Can we use data from it? And most of us are used to the secondary use of EHR data relating to clinical research or quality metrics. But there's actually, the EHR is actually a really good source of timing data because almost all recorded information in the EHR is timestamped. So if we can mine this data and we can find essentially how long things are taking in clinic, then we have a really good source for our models for that large data. So the very first thing we did was to look at the workflows of the clinic, make sure we understood them, and then validate the data from the EHR to make sure that it matched our workflow. So we studied 4 outpatient clinics in ophthalmology, 4 different subspecialties. We chose ophthalmology because it's a fast-paced specialty, combines medicine and surgery, and the clinic workflows are actually multiple stage and complex. We observed each of the 4 clinics for at least 4 half days to see what the workflow was and to actually take timing measures so we knew how long each of the steps took. Then, once we understood that, then we went into the EHR to look for timestamp data that matched it and then validated to see how close we got to our observed. So the first thing we did was we determined what the workflow was for the clinics. And as it turns out, for each of these 4 clinics, it's very similar. We're actually studying a 5th clinic where the workflow is a little bit different, so that'll probably be a future talk. But this is, patients come in, they arrive, they check in, and then they go to the waiting room to wait for the exam to start. And at all of these clinics, they used ancillary staff. Sometimes it's an orthoptist, sometimes it's a tech that does an initial exam, sort of does the initial, examination of vision or of the eyes. And after that exam, the patient's eyes may be dilated. If they're dilated, the patients return to the waiting room, so they free up that exam room while their eyes are being dilated. And dilation usually takes about 20 to 30 minutes. And in each of the clinics, the frequency of dilation varies. So in some clinics, it's almost all of the patient's eyes are dilated. In other clinics, very few of them are. But once the dilation is done, or once that initial exam is done, if the patient's eyes weren't dilated, then they're ready to see the physician. And they're in an exam room waiting for the physician. The physician examines them. They return to the front desk where they check out. An important thing before I go on to mention is in between that initial exam and the physician exam, the staff members have to complete documentation from that initial exam because it's used by the physician during their evaluation. Okay, so then we went to the EHR, we went to the OHSU Epic Data Warehouse to look at what timing information was there and what we could get that matched our workflow. So first of all, the check-in and check-out times are events that are recorded in Epic and are very readily available. We did find, however, for one of our clinics, that the checkout time wasn't reliable. In that clinic, the patients aren't required to check out at the front desk before they leave, so the front desk staff just check them out when they notice that they're gone. Some cases, it's when they leave. Some cases, it's like 3 hours later, like, wait a minute, what happened to the patient? Oh, they're gone. So we couldn't use that timestamp. However, we know at the end of every exam, the after-visit summary is printed. So we could use that as a surrogate for the end of the exam. For both of the exams, the initial and the physician exam, we used audit log data. So audit logs are required by all electronic health records that record, essentially what's done by anyone who's in the EHR, and they're time-stamped. So we were able to use contextual data about the patient and where they were in terms of the, which workstation they were on to figure out when, which timestamps occurred with the patient in an exam room with a staff member or with the physician. And we just looked at, and we found the first one and the last one, and then took the difference, and that became the length of the exam. The dilation information is in a template, it's in a smart form in Epic, and so we were able to get from that information whether or not the patient's eyes were dilated and if they were, at what time. So once we had all those pieces, then we could figure out exactly how long the patients were waiting. And notice they wait essentially in 2 spots, either for the first exam or for the physician exam. Okay. So when we compared them to the EHR, when we compared the EHR timings to the observed, well over 50 to 60% of the exams fell within 3 minutes of the observed time. So they were actually pretty close. Where they didn't match were that some of the staff in some of the clinics once the initial exam is done, and the staff remain in an exam room and do that documentation that has to be done before the physician exam. And so when we went through the EHR, it was very difficult for us to determine when the patient left, and when they were just doing documentation. So for those cases, the staff initial exam was overestimated. However, the documentation time is part of our workflow and is going to be part of our model. So in some sense, it doesn't matter if it's counted as part of the exam or as a separate step. But remember, for our simulation models, we really want a large amount of data. We want the data to represent the large variability that occurs naturally in a clinic over time. So we wanted to look at a year's worth of EHR data and see how does it compare to what we observed. Are we in the same ballpark? And so what we did is we just looked at density plots of both of those sources. The red is the EHR data and the bluish green is the observed. And in most cases, there's a lot of overlap, and the overlap is what we want. We want it to be representative. It's going to be a little bit different because the N's are different, for one thing. So we'd expect with the EHR having a much larger N that we'd have a much larger variability within the EHR. And there is just some that's a little bit different depending on the documentation patterns of the staff members. Okay. But this overlap indicates promise that we can use this EHR data for our models. So that leads us to steps 2, which is building our simulation models. And what we used was a simulation called discrete event simulation. And what that is it breaks down any process into a series of discrete events or steps. And each of those steps takes a certain amount of time. If the step takes a constant amount of time, that's easy. You just put that in as a constant. However, in most processes, the individual steps, say like the initial exam or the physician exam, are variable. They're going to take a variable amount of time. And so what we do then for that step is represent that time using a probability function. And we can base that probability function on the data that we get from the EHR. And as you can see here, we use Arena simulation software by Rockwell Automation to do discrete event simulation because that's sort of the leading software tool for DES. But the other parts of the simulation are, it's sort of like a flow chart. So there's decision points. So for example, we'd have the diamonds there for decisions like, was the patient dilated? If the patient's dilated, it goes down this path. If they're not, it goes down this path. So it's sort of like just a giant flow chart, and you just go through. Now, because there's so much variability, and because each time we go through this, like we'll simulate a clinic, and we'll have a patient come in and they sample from the probability distribution, how long that initial exam took, how long the provider exam took. We have to run the simulation multiple times to get a good idea of what the behavior is over time and how that variability affects things over time. So this isn't something you just run once. We run it hundreds or thousands of times to get a good idea of how the system behaves. So going back to our clinics, just as a reminder, we sort of have 3 big steps where we need data and where, sort of most of the work is happening. And that's at the patient arrival and the 2 different exams. Okay, we still have other things happening like documentation or dilation, but those aren't as big. And what we really needed our data for from the EHR was to represent the variability of the patient arrivals and the exams. Now, the patient arrivals in these outpatient clinics, all the patients are scheduled. So we're not trying to model, say, for example, the variability of a walk-in clinic where people aren't scheduled, you don't know who's coming when. However, in our model, we didn't want to just take the data of all the arrival times and then plug that in, because our model we actually wanted to see and play with the scheduling. So what we did instead was we did a combination. We looked at both when they were scheduled, and we didn't want to use just the scheduled times as when the patients arrived, because that doesn't represent a real-life system at all, because anyone who works in clinic or has been in clinics knows that patients never arrive at precisely the time that they're scheduled, right? So instead what we did was we measured the delta, so the difference between their arrival time and their scheduled time. And we used that as a probability distribution, and we added that to their scheduled time. So that's how that was modeled. And then we just had probability distributions for the 2 different exams. And The other thing that's important in simulation models are the resources. So each of those steps that happens in discrete event simulation has a time, but it also has, what is it using in the system? And the resources in our system are people and exam rooms. We didn't get at the granularity of modeling any types of equipment or anything, because most cases, those equipment belong to the exam rooms. So in our case, our exams both take a person and an exam room. Okay. And the waiting or the queues happen when patients are ready and are there, but the resources are busy. So either there isn't an exam room open for them to be seen in, or the person, the staff member or the provider, isn't ready to see the patient. So there's actually two possibilities for waits. Okay. So we built a model for each of the 4 clinics, and we modeled a half-day clinic. Okay. And to do this for each of the clinics, we needed information about that clinic. And we were able to get it from both the EHR data and from interviews with clinic staff. So the types of things we got from the EHR data were the things I've mentioned so far. So, what was that arrival delta distribution? What are the exam distributions? How long were staff spending doing documentation in between the exams? And, how frequently are patients dilated? Other things we got from interviews. So, talking to the clinic staff, how many ancillary staff members do you usually have during clinic? How many rooms are you using? How many patients are typical during a half-day clinic? And even though we did interviews with staff members, we still validated a lot of these values from the EHR, because it turns out, if you want to find out exactly, on average how many patients are being seen in a clinic in a half day, the worst thing to do is to look at someone's scheduling template, because we've got these templates and then found out when you looked at the EHR and saw actually, who actually showed up, is that the templates give you kind of a starting point, but for some providers, their templates are never filled, so they never fill their full day. Other providers have a template and says, we're going to see 10 patients, in 3 hours, but actually they saw 18. And so they're always overbooking. So we had to use kind of a combination of what the clinic said and then what the EHR data told us to determine exactly what all those different parameters were for the clinics. Then we ran each of the models 1,000 times, and the metrics we were looking at for validation were, are we in the ballpark for the exam times, what we expect to kind of give us a sanity check that these are working, and the patient wait times. Later on, we're going to be looking at different output metrics from the simulation models. So these are the 4 clinics, and we compared, in this case, the distributions of the exam times. So the red are the exam times that we got from the EHR. The green were the ones that we measured, and we sort of saw that before. And then the blue represents the average exam times that the simulation model gave us. Okay. And if you look at between the red and the green, they're kind of what we expect. The reds are, the red values are a lot broader, have more variability than the green do. There's one clinic where there's a shift here in glaucoma. And that's because we were overcounting the exam time with the staff members because they were doing the documentation there. But with the blue, the reason that the blue is a lot narrower than the other ones is just sort of an artifact of the limitation of the simulation model. When we were trying to get data from the simulation model about what was actually going on, the only data, the granularity we could get at was the average exam time per clinic day replication. So we weren't getting the actual exam times for each encounter. And if statistics, when you plot the distribution of averages as opposed to the raw data, the variability is much narrower, approaches normal. So that's why those are more normal. But what we're looking for is overlap and, kind of convincing ourselves that we're, representing the system at least somewhat. And then we did the same thing for wait times. And the wait times overlapped a lot more. And it's sort of the similar type of thing, looking at, the difference between the EHR, the observed, and the simulated data. So we have some confidence, at least for the proof of concept, that we're getting close. So we wanted to use these models to start answering questions for the clinics. And oftentimes, clinics, one of their first strategies for addressing inefficiency is to say, hey, can we add more resources? Can we add more staff? Can we add more exam rooms? Is that going to help us? And so what we did was we ran the models for each of the 4 clinics using different numbers of staff and different numbers of exam rooms. And what we found out was there was a big decrease in wait time when we went between 1 and 2 staff members or 1 and 2 exam rooms. There was a little bit when you went from 2 to 3, but after that you can see it just completely flattens out. And the reason for this is that once you get, a couple of staff and 2 or 3 exam rooms, those resources no longer become your bottleneck. The bottleneck is actually your provider. But the way that clinics are essentially defined in ophthalmology is that it's one provider in the clinic, so it's not like we can add more providers. And what can happen is that when you start adding more staff members, so let's say you have 4 staff members and you think, oh, I can see 4 patients at 8 o'clock in the morning. Well, those 4 staff members will see those 4 patients, and then all of a sudden at 8:15, the provider's got 4 patients waiting for them. So that provider really becomes a bottleneck. So because the clinics we all looked at were already using at least 2 staff members and at least 3 exam rooms, these showed, the clinic managers, there's no benefit to try and improve efficiency by adding any more resources in those areas. So instead, what we focused on, which is the third part of this, is how can we do different types of scheduling, and how can that address our inefficiency and improve wait times? So clinics will tell us, and we've observed this ourselves, is that clinics, any particular half-day clinic session, there's going to be spurts where the clinics are very busy, there's a lot of patients, and you might have like 4 or 5 patients waiting for a doc. And then there's going to be times when the provider doesn't have anything to do because all the patients are either being seen in their initial exam or in the waiting room being dilated. So you kind of have these, they say it gets bunchy. And so what we're trying to do is see, there are outpatient clinics. The patients are scheduled. We have some control about when they arrive. Can we make them arrive in a smarter way so that there's a more steady stream of patients, so we don't get this bunches and we have less wait time? So from the literature, we know that scheduling patients according to length and variability can actually improve wait time. So if we know which patients are going to take longer, we can actually schedule them smarter so that they're not disrupting everyone else. Because if you have a unexpected long encounter, then you get behind and then you never recover, okay? So we went back to and we realized, okay, so our EHR timing data give us information about exams, but we also have data about the actual patients themselves and what was done during the encounters. So can we connect the information to be able to predict who's going to take long? Can we figure this out? So in the case of the pediatric clinic, we were able to identify, both looking at the EHR data, but also talking to clinic staff, because clinic staff know, which patients take longer, is that the new patients take on average longer than a return patient. The other thing they were able to tell us, too, was that their child patients take less time than their adult patients do. And it may seem strange that pediatric clinic sees adult patients, but pediatric ophthalmologists treat strabismus. And so if you're an adult that had previously untreated strabismus as a child, you're going to go see a pediatric ophthalmologist. So they already had some sense, and we can already identify pretty easily that there's a group of patients here that are going to take longer. So if we know this, then can we do scheduling a little bit better? So the other thing we wanted to look at was what's the impact of these long encounters on wait time and on a clinic day. And so, there's going to be a certain demand for for these patients. They're going to take a long time, for a given month or a year, or whatever it is. But if they're not scheduled in a smart way, you can have clinic days that might have 10 long encounters and some days that don't have any. So we looked at the data and found out that there's a big range between how many long encounters actually appeared in a clinic day for each of the clinics. And the resulting wait time was really dramatic. Sometimes it's 2 or 3 times the amount of wait time that you would have with fewer long encounters. So if we can limit the number of long encounters per clinic session to be some value that's going to still meet demand, but just kind of regulates it so that you have less variability between days, we thought that would be a smart strategy. Now, the other thing is, where do we put these long encounters once we have them? And this is hard to see, but what I wanted to show you is that for all of the clinics, the patterns were the same. So, if we put them at the beginning of the clinic, we reduce the overall clinic length, but we increase wait time. So just to give you a closer up so you can see better. And this is sort of counterintuitive to what a lot of clinics already do. So a common scheduling strategy for clinics is to put the long patients, the ones that know they're going to take longer, at the beginning of the day, because they want to get them out of the way, and they don't want them to necessarily extend the length of their clinic. Okay. And we can see that if we look at the orange line, you can see that, and along the x-axis here is where the position of those long encounters. So 1 would be at the beginning of the clinic day, and 13 would be at the end. So when we put them at the beginning of the day, you can see that the clinic length is minimized. But the blue, which is the wait time, the patient wait time is actually maximized. And what happens is when you have long encounters, especially ones with big variability at the beginning of the day, clinicians often get behind and they never recover, and it just sort of snowballs. More and more people are there, and more wait time, more longer queues. So the closer we can get them to the end of the day, the less those long encounters impact everyone else's wait times. Okay. But this is the nice thing about the simulation models, is that we can present graphs like this to the clinic managers, because it's not clear necessarily that you'd want to put them at the very end of the day to minimize wait time when it's going to, unnecessarily sort of lengthen your clinic length. So you can give this information to the clinic managers, and they can make a decision as to where to put them. Well, maybe it makes sense we'll put them in the second half of the clinic, but maybe not at the very end, so we don't have a really long clinic day. So then the pediatric clinic asked to refine this strategy a little bit more. And this is based on their own intuition and some of the practices that they're already doing in clinic. So what they wanted to do was they wanted to bin the patients into 3 categories instead of just long and regular. So they wanted the short patients. And the reason for this is that they were already sort of ad hoc managing the short patients on their own. So they weren't necessarily scheduled in any slot, but if you had a group of patients that were waiting to see a provider, they would just naturally take the next patient that they thought was going to be the fastest and get them out the door, even if that patient hadn't been there as long as some of the other patients. Does that make sense? So they're kind of letting people leapfrog because they know they're going to be shorter. So if we can identify those short patients and put them at the beginning of the day, get them out of the way, they're never going to wind up in a queue, they're never going to wound up being impacted by someone who's longer, then we can start decreasing average wait time for everybody else. The other thing that they asked was, what happens if we put a blank slot in the middle of the day that allows for some catch-up period? Is that going to decrease our patient wait time? And so we went back to the simulation model and ran it and said, okay, well, what happens if we have no blank slot, which is the first point up there, and then what happens when we start scheduling that slot at the first slot, second slot, and so on? And we found that the minimum was at blank slot 10. Okay. And so that's what we did. And we have been testing it in clinic since then. However, we don't have a lot of data yet because it's really difficult to come up with these test days on any short notice. So they did free up, when we initially started testing, they'd free up a day like in 2 or 3 weeks. They'd add another clinic. But the problem is that you can't get a good mix of patients in just 2 or 3 weeks of lead time. That when, especially in ophthalmology clinic where you have patients who come in regularly, like every 3 months or 6 months, you really need to have those days kind of far in advance and be filled more naturally with the general mix of patients that you would normally have. So we're still working on testing this, but so far we've had 2 good days of half days that we've been able to test it, and the average wait time was significantly smaller than our observed days, our 9 half-day clinics that were similar. So we think that this has promise, and we're going to be continuing to test it. We had a test day this week, and we'll have a test day next week and hopefully we'll get more data as to how this is performing. So, but of course, anytime you're working with a schedule, especially a schedule that becomes more and more prescriptive, it becomes more and more difficult to schedule because, you know, patients aren't always available when you want them to be, and they may want different slots. And so we've gotten a lot of comments from the schedulers. You know, one thing is, you know, I need more slots for what we consider the medium encounters, or I'm not filling the short slot. What should we do? So we use simulation. We tweaked the model a little bit and said, okay, well, you can put the medium patient in this particular short spot, and it will only, you know, it shouldn't impact the system too much. The other big question they had was, you know, where do I put urgent patients? So if I have to double book someone, where do I put them? And we thought, well, you know, just put them in that blank slot. Well, we ran the simulation models, and actually what it showed was it didn't matter. And I think it's because our schedule was already sort of optimized, and once you put them in the bank slot, they were already doing catch-up during that period, so it really didn't decrease wait time to put them in that blank slot versus double booking them in another slot. The only thing that it showed was there was a slight decrease in wait time if you put them at the very beginning of the day or at the very end of the day. But it sort of reassured them, you know, yes, you can put an urgent patient where you'd like with the schedule, and it shouldn't have too much of an impact. Well, it does have an impact, but it doesn't change. That impact doesn't change based on where you put it. So this work has some limitations that we're still working on. The EHR timestamps really can't capture, in some cases, the full length of the exam time because, you know, staff or providers will have portions of the exam that happen either before they first use the EHR or after they stop using the EHR. So we're looking at different ways within the EHR, different reports that, that might get around this a little bit. The other thing we're looking at is doing some automatic data collection that might be better at getting more exact exam times. But the other big one, too, is that we have to be able to predict which patients are going to take longer or which patients are going to be shorter in order to implement these schedules that we've defined. And it's really easy in a simulation model to say, okay, this patient's going to be short, we'll put him here and run the model, but, you know, how do we know who's going to be short? How do we know who's going to be long? So we've done some initial work on this, but it's actually pretty tricky because there's so much variability in these exam times that there aren't a lot of big things that pop out as being big predictors of somebody who's going to take longer. We know that new patients take longer. We know certain diagnoses will take longer. Certain procedures like dilation takes longer. And in the case of the pediatric clinic, we know that ages can take longer. But really, through our observations and through talks with different clinicians, a lot of times the things that sort of make an encounter long are things that we have no data about. There's nothing in the EHR that tells us when a patient's going to be chatty. And so how do we address that? So we did a study a few years ago where we looked at, we observed in clinic, and we looked at the different exam times and then saw and broke them out on these different categories. And so this was in the pediatric clinic, and the blue bar represents the provider, the orange is the tech, and the green is the orthoptist. And so the tech and the orthoptist are the ancillary staff that do the initial exam. And the basic difference between them is that the orthoptist sees patients that have strabismus, and the tech sees patients who don't. So anytime you see a green bar, essentially you're looking at strabismus patients, and the orange are everyone else. So you can see that, for example, the one in the middle is age. You can see that the toddlers, not surprisingly, take a lot longer for the provider, and the adults do as well. You can see that dilated exams, now this is just the exam itself. It's not the time that it takes to do the dilation, but once you're with the provider and you have dilated eyes, the exam actually takes longer because you're doing a different type of exam. And new patients take longer. But one of the things that we did as part of this study is we wanted to see, could the providers identify which patients were going to take longer? And so we called it complex as opposed to taking longer. And as it turns out, the patients they identified as being complex, and this could be complex based on a diagnosis or just on the patient being chatty. And as it turns out, the ones they identified as complex were longer. So this indicates to us that providers really can identify and are a good source of information. And so because we already know that the new patients are going to take longer, and those are sort of the unknowns, we just put them in the long encounters. But anyone that's a return patient, the provider, has a follow-up form, and they have on that form, what slot they think that patient will need when they're scheduled next. And so that can be based on the type of exam that's going to be next, or it can be based on the patient. So that's the way that we're hoping that we can address this problem. So in summary, we have been able to show that the EHR can actually be used as a tool for improving clinic efficiency. It's not just the maligned, thing that that's ruining the clinician's efficiency. We showed that our simulation models can be very effective. They can be used for testing different clinic configurations, different types of resources. We can provide clinic managers with information that allows them to make smarter choices about their clinics, how many resources, how they want to schedule people, and where. And these results appear to be generalizable. For the 4 clinics we looked at, now granted they had similar workflows, but all the models showed essentially the same patterns. What happens when we add more resources? After a certain point, there's not much of a return. When we put the long encounters in different spots for all of the clinics, it increased wait time the earlier they were in the clinic, but it decreased the clinic length. So this sort of, gives us some confidence that these results aren't just unique to a particular clinic and might be generalizable even outside of these ophthalmology outpatient clinics that we looked at. And it really broadens the EHR into tools that can be used for workflow improvement. So that's it. If you have any questions or comments, I'd love to talk about this with you.
That's really great work because there is a lot of that timestamp data that's available. One of the things that I didn't hear was provider intervariability. Is that something you looked at all? I mean, some providers are going to be much more efficient than others, and maybe the ones that are inefficient need more time.
In terms of, we were just sort of measuring how long they took. So we weren't necessarily comparing them to one another or seeing what that impact was on the overall workflow. So we weren't really trying to identify, and I think this is, we sort of did this from the beginning sort of to gain confidence and to gain collaboration, is that we didn't make it about the staff or the providers trying to evaluate them as to whether they were taking too long or too short, right? We were saying, okay, this is a given. We're going to measure how long you take, and given that this is how long you take, can we schedule people better? Okay. So I don't think we have plans to start looking into that, because that's not, but I think there are other people in KCI Institute that are addressing that problem a little bit more directly.
I would, do you want to talk about some of the stuff that Sarah, I mean, Michelle, Homer, in terms of what you're talking about, Michelle's worked with someone named Sarah Reed Brown, who had looked at, Sarah's back there, who'd looked at sort of how long each provider takes documenting. And that's not exactly the same as what this, but it's very closely related to efficiency. Fastest is 7.5 minutes per patient. Slowest is 45 minutes per patient. Now, they're very different types of medicine that they do, but I agree with you that there are huge variabilities here.
Mm-hmm.
You probably considered that. You were looking at patient variability primarily, and then you asked the providers to sort of predict who is going to be a quick and slow patient. But you probably considered that elsewhere in the medical record, you have lots of timestamp data, and that slow patients in the ophthalmology clinic tend to be slow patients in the dermatology clinic and the internal medicine clinic. And that might be a source of predictability.
Yeah, and we are looking at, sort of past exams as predictor. We hadn't really looked outside the specialty, however, but that's a good point. That would be a way of doing prediction, especially for patients that maybe hadn't been in ophthalmology for very long. So you can, so you can look. Yeah, that's a good point.
In your simulation, are each of the distributions for the events separate, or is there some covariance in between there? And this is kind of getting at, like, if you have a slow patient, they're going to be slow in each one of these.
Yeah,
categories.
and that's a good point. No, right now they're independent, which isn't necessarily the case because they're sort of independent. So if you're a long patient, you have separate distributions for the initial exam and for the provider. So they're dependent in that way, but you don't have within that category, you're not trying to connect the initial exam to the, and there is a lot of covariance. That's a good point. We haven't figured out how to manage that yet. But yeah, sure, right, because it really wouldn't be realistic that if you had, a really long patient, that somehow when you did that initial exam, you sampled something that wound up on the shorter end, and yeah. So we're looking at different ways of doing that. And we did do something initially where we were splitting up patients based much more fine-grained, and so they were more connected. But those models were much more difficult to manage, and especially when they translated into scheduling, a lot more complicated for someone to manage. So we're going to have to go back and figure out how to make them a little bit more fine-grained, I think.
EPIC has two levels of audit trails. There's a standard level that's turned on all the time in all clinics for all providers. That's mostly for compliance purposes. Right. There's a separate additional level that you can turn on that's much, much more data intensive. Which of those have you been using?
Just the regular, not the data intensive one.
Not the data intensive one?
Right,
okay.
Right,
and,
yeah.
and so follow-up question then, have you thought about looking at that additional level of audit trails in order to get more granular information?
Yeah, we did get some of that data initially, and it was a lot more difficult to deal with because it didn't connect as well to like the encounter, and so we could match up exactly what was going on with that particular patient and where. So no, we didn't, at least for that particular data. The other thing is you have to turn it on, and we could do it, but we wouldn't be able to do it for a really long period of time. So we sort of sacrificed that, instead of looking at, over time and being able to get a year's worth of data.
Yeah, that makes sense. You definitely can only do it for like a day at a time.
Right, exactly.
For a period of time.
Right.
But sometimes to at least validate your more generalizable tool, that can be helpful. Did you consider doing RFID tracking of patients, again, as a sort of a gold standard automated way of validating it?
Yeah, we're actually considering not using that, but iBeacons and using some sort of iOS device where they would go and they'd be tracked that way. We've done some testing with it and have had some issues with it's kind of difficult when you're trying to get at a granular level where everyone is, and you have a bunch of sensors and they wind up competing with each other, so you think you're someplace where you're not. So we're still working on that and getting that to work.
So the sense that I get is that you're using wait times as sort of a surrogate for overall efficiency. Are there reasons to believe that that is a great measure of efficiency, or are there other ones? And then also, are there measures of, I guess, clinical outcomes or effectiveness
Right.
of treatments and stuff like that?
Yeah, that's a really good question. The other things that we have considered using, besides just wait time, would be things like, what's the maximum size of the queue, for example, or what's the utilization of the providers or the staff members, because all of that gets to, are you using, are people remaining busy most of the time? The wait time was just the one that was the easiest to determine from the simulation models and to compare to what we could get from the EHR data as a way of validation. We're still working on some of those other ones, but they're a lot more complicated to try and see. The other thing that that I've been wanting to do for a while is actually creating data visualizations of an actual clinic day, so you can actually see these patterns and see, what's going on with efficiency. Is wait time the best one, or are there other triggers that we can see earlier that are going to, show us when we start getting off track? But in terms of the clinical effectiveness, no, we haven't looked at that yet, but that's a good point.
If I can just add to your response on that, the wait times in clinic have traditionally been used as a marker for efficiency and also are very, very strongly related to patient satisfaction and other clinical outcomes, as well as cost issues in clinic. What's interesting, though, is that it's largely around how you manage patients' expectations. So if you update them every couple minutes that it's going to be a delay, their perception of that wait changes dramatically. So there are operational things that you can do to change the impact of that wait time.
Exactly, and it's sort of like, Disney is the master at this, right? Because if you think about when you go to Disney World or Disneyland, the majority of your day you are in line, but you are the happiest to be in that line than you'd ever be in your life. So, part of this research we think eventually will wind up being something like that, where it's information that's both given to the provider and to the patient about what the current status is. The metric of wait time is a very standard one, but it's not necessarily one that's very actionable, right? So how do we figure out when in the clinic and what can we do to adjust in real time? And so those are all the things that we're looking at in the future to try and make this more operational.
So by any chance, did you consider the no-shows in the clinic? Did you observe any patients who canceled at the last minute?
Well, there are always no-shows, and that always impacts things. And so what we did was I had modeled it two ways, which is, looking at the template and what we expected, and then adding the no-shows as a separate kind of rate, or looking at the data and looking at over time what that variability was in terms of the size and measuring it that way. And it just turned out easier to look at it from, instead of modeling it as a no-show, just looking at it as, the numbers that actually showed up that day, which is essentially the same thing. But that's one of the things that we're looking at, too, is how those no-shows impact and, and then how the urgents impact things, too. So how do those balance out and affect a wait or an actual clinic day and what the wait times are?
Have you thought of doing a comparison study with the VA?
No. Well, the interesting thing about the VA that I think would be an interesting study is, from what I understand, and maybe I have this incorrect, but is that they will have, some of their clinics will have multiple providers in the clinic. And so when you show up for that clinic, you may not be there to see just one particular provider. And so what's nice about that, that's sort of a different, there's different kinds of models for service and queues. And this is sort of a different model where you have kind of a group of people that are providing the service. So when you show up, you see the provider who's ready next. So that's sort of a different model from what we're using, but it's an interesting one because I think in a lot of cases that winds up being a lot more efficient than when you just have one provider per clinic.
I would like to add something to the initial question and comment by the previous commenters, is that there are some other metrics that can actually be tracked based on improving the clinical workflows, and some of them could be access or looking at the backlog and also the third next available appointment. So just getting a bigger picture of things could be the next step. In
yeah, and that's those are some of those factors that we've been using in some of our other studies to try and kind of understand the overall picture of what the patient volume is and when patients are seen and what that overall wait time is, not just within the clinic itself. Yeah.
Michelle, I'm actually wondering if I could ask folks like maybe Rob and Tim, because one of the questions about this is sort of what's the next step? In other words, how do you integrate something like this into the real world? And what I sort of, and I'm thinking two things in particular. One of them is that to query data, we, meaning somebody like Michelle or Sarah, has to query it, from the data warehouse. and secondly, to integrate that with the scheduling system. We have to, it's a very manual process right now. And if we were to try to, like if Michelle were to take that next step, and how do we take a system like this that she's been developing and get it into the real world with Epic or maybe with other EHRs in some kind of generalizable manner? What is the strategy that Michelle should take, with that? Is it, working with some kind of API to interface with, EHR scheduling systems in general, or how would you suggest that should work?
Let me think about that.
I think you're getting the data from Clarity, is that right? If you want something more real-time, you're going to have to go after Chronicles directly. And we have done that at Kaiser Permanente, and we get data probably every 5 minutes. And we're able to build a dashboard of what's happening in the clinic. So that would be one approach. I can put you in touch with the person that did that work.
Oh, yeah, that would be great.
And to follow up on that, Homer, that's a great point. In the emergency department, for example, now it's calculating wait time in the emergency department in real time and displaying that to providers. So when I'm in primary care clinic and I want to think about sending a patient to the ED, it says the wait time for adults is 3 hours and 42 minutes, and the Dornbecker Children's Emergency Department wait time is 2 minutes. So basically, I send all my adults to Dornbecker. So there are ways to build it in as a real-time feedback loop. There's also a whole bunch of opportunities with APIs to pull data out, even out of Chronicles, feed it into an external system, run your algorithm there, and then through data link feed it back into Chronicles in more or less real time, or at least maybe like 15-minute increments.
Can I raise one other question? Do you mind going back to those slides with the those slides?
Yeah, exactly. Not a mind reader.
The ones with the wait time and the clinic length. One goes up, one goes down. Because, this is a question that Michelle had talked about and we had pondered for a while, that the way that the metric of mean wait time is defined is that it's the mean wait time of all of the patients in the clinic. And one thing that we wondered about is that if your lung patient goes in first, it affects every other patient. And so by definition, it seems like there's an inherent bias that if you schedule later, you affect less people. Therefore, you impact the mean wait time less. And so we've never really been sure if this is a fair metric for representing the impact of a long patient on a clinic. And so I'm just wondering if people have ideas about what a good sort of unbiased metric would be for calculating disruption. In his mean wait time the best, given that, we're dealing with this temporal issue that, the earlier you place them, the more people that delay percolates down to.
Yeah, I think what would be more interesting to me is knowing, finding out what's an acceptable wait time and then what percentage of patients are beyond that.
Mm-hmm. Right, exactly. Yeah, because you're still going to have potentially patients in here that have very little wait time and then some that have more. So, yeah. That's a good idea.
Do any of these clinics, I know some clinics at OHSU now have a whiteboard and they put up expected wait time. And then if I know, 45 minutes, I think I might open up my laptop and start working, then I'm frustrated at the long wait. They already told me 45 minutes.
Right. Yeah, some of them have those up, but I don't know. Like, do you know how those are determined? Or, yeah, we've never figured that out. Yeah, that's my, yeah.
At least within the Department of Family Medicine clinics, the nursing staff or the MAs that are working with the providers have a pretty good feel of how many people have checked in, what type of complexity patients are. They get to know them. They know whether it's the provider who's a chatty provider. And it's kind of like the restaurant maitre d' who's like, oh yeah, you have a 45-minute wait for your table, and they're pretty accurate in that guess. So there's no formal metric behind it, but you kind of know how long your provider is going to be. And then in most of the primary care clinics now, they do have a whiteboard in the waiting room that they update pretty frequently to let people know. And as I mentioned earlier, that does make quite a bit of difference in terms of patients' willingness to sit there and wait.
Yeah, so I thought this was really interesting what you presented, and it got me thinking a lot about how like efficiency is measured and what the gold standard is, because I get the impression that like the providers who are able to run through patients very, very quickly throughout the day are like the gold standard, like everybody should be like whoever. But I also wonder if there's like a certain level of inefficiency that's actually necessary, and you had mentioned, for instance, you had mentioned earlier that like the slowest note writers are like 45 minutes. And it's like, well, is it because they type 7 words per minute, or is it because they're writing like small books for every patient? And then your shortest ones are like 7 minutes, and is that because they can type at 150 words a minute, or is it just because they don't document very much? And so I mean, I think there's a lot of other examples, but like is like schedule efficiency like is that like the thing that we should be going for, or are there other like measures that can be incorporated into that?
That's a really good question. And there is inherent differences between people and how long that they take. And yeah, that's a tough question, and one that we've asked a lot. You know, how do you represent what efficiency is? And you know, these discrete event simulation models are typically used a lot for like manufacturing processes, where you have, you know, a bunch of equipment, and you know, these little parts or widgets are going to go from, you know, equipment to equipment, and you know, they're measuring efficiency by, you know, things like utilization of the machines and what the output is. You know, how many widgets can they turn out in a given amount of time? And in clinics, it's a little bit different. You know, we could use patient volume, but sometimes patient volume isn't necessarily representative of efficiency. It's maybe, you know, the provider's preference, because each provider has a different preference for how many patients they want to see. And some of it might be limited by their own capabilities and, you know, how quick they are with different things, or how long they want to take with patients. So, yeah, it's really tough.
So you just brought up another issue that I think is continually interesting to me, and how healthcare industry is being compared to manufacturing. And I'll be damned to compare my patients to, like, you know, like an automobile processing plant or something. Like, these are people. And so it's really hard. I mean, like, I'd also dare to say that healthcare is unique in this sense. And it's not at all like a lot of other sectors where we can just like assemble, you know,
right.
the process.
No, it's totally different. And just because, you know, the discrete event simulation models are used for manufacturing doesn't mean they can't be used for healthcare, but it means that your interpretation of what they tell you is different, because it's not the same. And in some cases, you know, is it really bad that some providers take longer with some patients than with others? I mean, sometimes it's good. So, you know, trying to figure this out and, you know, even identify what's good versus bad is hard. It's complex. There's not always one answer. But we're just trying to, you know, provide data and provide information to people so that they can actually see, you know, what's the effect of this, what's the impact, and make decisions and make more informed decisions than what they had before, which is just sort of ad hoc, you know, well, you know, if we have patients waiting, you know, we'll take the one that we think is going to be the quickest first. Well, then if that's the case, if we can figure out who those quick patients are, maybe we should put them first anyway. So just trying to, you know, get these things a little bit more operational and give them more information to make better decisions. But certainly not trying to make them into manufacturing plants. That's not our intent at all.
Riffing off that just a little bit, as I remember, your plot overlays where you had the distribution of your model versus observed versus EHR timing data. I think the model had pretty fair central tendency agreement, but the overall variability was smaller. Did you play around with the parameters at all that affected variability for the model to see if your predictions were robust to that variability?
We did a little bit, but as I explained, you know, unfortunately, what we're showing here for the distribution for the simulation model is not exactly the same as for the others. These others are representing the actual variability between encounters, so each raw encounter, exam time, or wait time. But for the simulation, and this is sort of the limitation of our model, is we couldn't figure out how to get the exam time for every single encounter that went through our simulation model. So instead, we're getting summary statistics. We're getting an average for each replication. So when you start plotting the distribution of averages, you're going to get something with some, but at least the central tendency matches, but the variability is going to be smaller and more approaching normal because that's what averages do.
Does that get at the fact that there's probably many, many more variables in a real clinic that affect those, the variation in that versus the scenario in the simulation that has a handful of variables?
Yeah, the simulation models can only go so far. I mean, even when we use the probability functions based on the data, I mean, we sort of have to, identify which probability distribution and which parameters, and, they're still not going to match our data exactly. So there's going to be some mismatch there. But then there's all sorts of things that happen in clinic that is just almost impossible to represent in our simulation model, at least very efficiently or effectively. So, for example, in our simulation model, if a patient arrives, let's say they're 3 hours early and they arrive, in our system, there's still, the patients are prioritized in the order that they arrive. So if you have a patient that's supposed to come, at 11 o'clock, shows up at 8, you're going to take, if the 8 o'clock patient's there, you're going to take the 8 o'clock patient first. However, what can sometimes happen in clinic is that if the 11 o'clock patient shows up at 8, even if they're ready and, that there's, staff aren't busy or the provider isn't busy, they're not going to take that patient right away because they're waiting for their 8:15 patient to show up and their 8:30 patient, and they don't want that 11 o'clock patient to kind of get in the way. And so that kind of decision-making is a little bit harder to represent in the simulation model, to come up with absolute rules that are going to apply to every situation. So there is a little bit of mismatch, and so there's always going to be times when they don't exactly represent what happens in the clinic. Okay.
The question that was brought up and just what was talked about. Oh, sorry. So the one is, how do we model, if you, on your previous graph you were showing with the 2 X's, the relationship between dependence between the patients who come in the clinic, and that to me is a Markov process, and the time that you can use a hidden Markov model, and the latency could be the time that they're in the clinic, which it then is predicted by through going to the model. So that could be addressed that way. And also how you just brought up, it's more complex of what if a patient comes in the middle of, that's again another type of Markov model, which can have multiple.
Right.
So, and also then things like that will also get at giving you better confidence intervals for your graphs that gives you better, like you don't really know if that actually is a real separation, giving you a difference in time or not.
Right.
So those were kind of relating to all those.
Okay, thanks.
If anyone has any questions, please have them. Thank you very much.
Yeah, thank you for coming.